Okay, welcome to today's second event with Professor Dr. Karl Lauterbach. First of all, I would like to say a few words about our society, the German Society, in this year. This is our last event for this year, and well, we've just on Friday won a gold award from the SU, which we're quite proud of, and I hope that this really reflects on a truly amazing year for us, for which I'd like to thank our members, the wider LSE community, the support that we got from them, our partners and sponsors, and also our committee who made this entire year possible, including talks like today's. And we really hope to see you again next year for really another good session, if you're still here. And well, just a few words about tonight's talk. It will be a more general one on healthcare politics. Our chair will be Professor Prof Mossialos, Director of LSE Health, and well, he chaired our event with the Federal Minister of Health, Daniel Barr, and now he gets to see his more or less counterpart. So I guess that should be an interesting continuation of events. And I'll just now hand over to Dennis, who will say a few things about postal elections. So whoever's not German here, I apologize for this, but there's a very low turnout, and this is no party affiliation or whatsoever. You're not required to vote anybody, any party at all, but I think voting is in everybody's interest, so I'll hand over to him.
Thank you, Lawrence. Yeah, so I just want to steal 1 minute of your time enjoying Professor Lauterbach. And this is, as Lawrence just said, Germans abroad generally don't vote. And so the participation rates of Germans abroad in the last general elections, 2009, was about 3% compared to participation rate of French expats, 2012 was 13%, 30, yeah. So, and we as the local group of the Social Democrats, so the SPD, just want to increase, or we just want to tell you, just go vote, and also tell all your German friends, even though you're not German now. So please make your democratic voice heard and vote in the elections on the 22nd of September of this year. And what we have produced to make this as simple as possibly possible is to produce a manual for how you actually vote when you are abroad, and this is what you found on your chairs today. So, and then the very first link on this paper actually gives you the link to the PDF itself. So, so you have to think about this early. If you want to vote, you have to become active on the 1st of August if you're abroad. So that's why we are raising this awareness right now. And so please spread the word. Please go and vote, and yeah, make more democracy, or generate more influence from abroad in the German political process. And yeah, if you're not German, please take it to your next German friend, or post the link on Facebook, whatever. Do what you think is useful to spread the word. Okay, thank you. Over to you.
Thank you very much, and thank you again to the German Society for inviting me to chair a very important lecture, particularly in view of the forthcoming German election, which is going to be probably the most critical election that is going to define the future of European politics in the next 20 to 30 years. That's my personal opinion, but I think you are sharing this view. Europe is in a very critical conjuncture these days, and Germany is playing a very important role. And many of us who are not Germans are looking for European Germany in the next few years rather than a German Europe. And therefore, the result of the German elections will be very decisive. But we are here to discuss, not to discuss German politics or European politics, but to discuss health policy and politics. And we have a leading expert, not only a leading politician. It's good that we have a leading politician, the health person of the Social Democratic Party, but it is very important to point to the fact that Professor Lauterbach is one of the leading international experts in health economics and public health. And it is quite rare to find politicians who have studied the subject of their politics, whatever this might be, health or education or foreign affairs, although there are a few LSE graduates who are now in government, and they are ministers or prime ministers, who have hopefully learned a few things in this institution and are managing their government affairs quite well. So we have a politician who is evidence-based, and that's very important. So if you are to challenge him, you have to come up with facts and figures, not just with opinions. And we're very much looking forward to a lecture that will be evidence-based, not only ideologically based, although the title implies that might be a bit ideological, to have a single insurance system rather than a two-tier system. And many of you might think that having a single insurance system might be more hierarchical, might be a bit more bureaucratic, might be a bit less competitive, but you can well have a single insurance system and have competition and have choice and have a healthcare system that is closer to the needs of the population rather than far distance from the needs of the population. So we're very much looking forward to an evidence-based lecture on why Germany should establish a single insurance system and move away from a two-tier system. Thank you very much.
Thank you so much for this generous introduction. I'm clearly representing a party that wants to have Germany to continue to be a European Germany, and we are not lobbying for a German Europe, as a matter of fact. So this is clearly, from our perspective, would clearly be a nightmare, and we clearly support the policies that are currently undertaken to maintain the European political structure as it works, which you pointed out, because I think I'm in agreement with you that we are, let's say, looking into very important elections, not only in Germany, but also in other countries in the next months. But this is not my topic today. I will focus on the healthcare system in Germany. And the German healthcare system so far is indeed, what many people do not know, a two-tiered system. We, as a matter of fact, have two systems in one country. We have a private system and a public system. The public system is what we call the statutory health insurance system, SHI. It covers 90% of the population. About 10% of the population, 11% are covered by the private insurance. And the way the system works is that you have to have a minimum income in order to be able to opt out from the public system. So if you earn less than 4,000 euro per month, roughly 4,000 euro per month, you have to stay in the public system. And if you earn more than 4,000 euro a month, you can choose whether you opt into the private system or stay in the public system. And those who are in the private system and are 55 and older can never return into the public system anymore. Those who have opted for the private system and are younger than 55 can only opt back if their income falls under the 4,000 euro threshold. This is roughly how the system works. And the systems are in competition with each other. The public system does have a comprehensive benefit package, which is a universal comprehensive benefit. This is the same benefit package for all sickness funds. We have 140 sickness funds, but they all have the same universal benefit package. The benefit package covers drugs, hospital treatment, outpatient care, specialists and primary care, and also medical devices. So it's a fairly comprehensive package. It includes everything that has been shown to work, which is so-called evidence-based, and it also covers everything which is, let's say, cost-effective. So it does not include treatments that have never been shown to work or are prohibitively expensive. For example, it does not cover alternative healing, for example, because alternative healing has never been shown in studies to work. So it's not covered by the system. And it also does not cover positron emission tomography for heart disease, because this has never been shown to be cost effective, because it doesn't, let's say, make a difference to the treatment decision. But whatever is evidence-based, roughly speaking, not only by randomized controlled trials, but by other forms of trials, in one way or another evidence-based, and what is cost-effective and how this is determined, I will explain later, is covered by law and has to be offered by all sickness funds. In the private system, a lot of those treatments which are not evidence-based are also covered by the funds, because the funds, the private companies, they are not limited by this universal coverage law. So they typically cover whatever is covered by the public funds, but in addition, they cover a number of things that are not evidence-based, which go beyond the universal coverage system. This is very often then done for marketing reasons, because, for example, if you look at alternative treatments are often well liked by people who are healthy and have high income. If you have high income and are healthy, studies show that you may prefer alternative treatment. If you are older and are sick, you actually may want to be treated in the way doctors in the hospitals recommend you to be treated. So therefore, a lot of what the private funds additionally offer is either not cost effective or it is not shown to be based on studies. Therefore, for example, positron emission tomography for heart disease is paid for by most private funds, at least in many cases, despite the fact that it does not influence, on average at least, medical decisions. The payment scheme for the privately insured is different in both hospitals and for office physicians for the same treatment. All public funds pay the same honorarium and the same DRG for comparable patients, so there is no price competition within the public system. In the private system, there is an alternative payment scheme which pays about double the amount of what the public system pays. This is a substantial difference, because this basically makes private patients much more attractive to physicians and also to hospitals than public patients. You basically get double the income per patient if it is a private patient. Now, if this is, for example, a procedure, and the procedure has, let's say, a cost which is, let's say, 80% of what you are reimbursed by the public insurance, then in essence, if you are paid double that price by the private insurance, you have 6 times the profit, because the costs are the same, but you basically have not 20% profit, but you have 120% profit. In that sense, privately insured patients are very,
very lucrative to hospitals and to physicians. And about 95% of all physicians prefer private patients. Also patients on average prefer private patients. Studies, for example, show if patients test patients, dial physician offices, and they basically say, this and this is my complaint. I want to have an appointment with your office. And then the question is, are you privately insured or publicly insured? Then the waiting times are 2 or 3 times as long if you are publicly insured in comparison to being privately insured. Obviously, whenever you would ask a physician whether he makes a difference in making appointments for publicly or privately insured, almost all physicians exclusively say, I never made such a difference and I do not intend to ever make such a difference in the future. But if you have test people to call, you always find the difference. And if you later confront these officers, what happened, it is often an office mistake made by someone working in the office, not to the knowledge of the doctor himself or herself. And it's the same in hospitals. University hospitals, on average, let's say, prefer private patients. For example, in large university institutions, the percentage of privately insured patients, in particular when we speak about specialists, is much higher than the 10 or 11% that they represent in terms of the population share. So therefore you have an overrepresentation of privately insured in specialist institutions, and you have an underrepresentation in institutions which are known to be low quality. If you look into a hospital which is known for low quality, where many of the doctors are, let's say, non-native language speakers, where there is understaffing, and where there was scandals in the past, then you will recognize quickly that the number of privately insured patients is less than 11%, maybe 2%. If you go into a university institution like Cologne, my university at the University of Cologne is very, very much specialized in cancer treatment, among the 2 or 3 best institutions in Germany. We have an overrepresentation of privately insured. So in that sense, we have a 2-class system, and money drives the selection. But the problem with this is that the privately insured, they also do not always benefit from this difference, because they are often, in comparison to publicly insured people, overtreated. In Germany, the number of procedures done even on publicly insured patients is very high. We, for example, have, roughly speaking, more than double the number of knee and hip replacements per person, age adjusted, than the UK or France in the publicly insured. But the odds ratio of having such a procedure if you are privately insured is even much higher, because in the privately insured you can easily make a substantial amount of money even with a single case. So in that sense, the privately insured are at risk of being overtreated. In this week's issue of Der Spiegel, which is, let's say, a very well-known weekly newspaper, it's actually the most read weekly newspaper in Europe. A journalist, privately insured, had major problems in a hospital. I do not want to mention the name of the hospital, but she expressed it in the following way. She, as a privately insured patient, was looked at like euro notes with legs. And she sustained an ordeal. For everyone who was able to read this in German, it is very worthwhile reading. So it is a prejudice to believe that the privately insured are always the winners of the system. They have a better access to specialists, but they may be over-treated when they are looked at from an economics perspective. And the system, in a sense, also is inefficient in the following way. Many of the specialists spend a lot of time doing simple cases in those patients who are privately insured, because this is very, let's say, lucrative, rather than focusing on the difficult cases in the publicly insured. I'll give an example. It is not rare that, for example, GI surgeon is working on hernia repairs in a privately insured patient, while his assistant is working on a difficult colon cancer patient who is publicly insured. So this is, let's say, the incentives are very obviously. All physicians would immediately deny that financial incentives play such a major role, but the evidence speaks a different language. We see this. So that is one of the reasons why we as Social Democrats, but also the Greens and also the far left, we want to change the system. We want to have one universal system for all of Germany, rather than two competing systems, one publicly funded and privately funded. The publicly funded system and the privately funded system also have additional differences. I skipped this. The slides will be made available to you by, who will make the slides available? Lawrence will make the, how will we post the slides? Because I skip a number of slides, otherwise it will take too much time.
We will post them on the German Society website and also on the LSE Health website.
Wonderful. LSE Health and the German Society. Thank you so much. So this, because the slides have a lot of details how the German system works. Many of you who sit here are students and would, let's say, have more rigorous information and more extensive information than what I can deliver in so short a talk. This is on the slides, and I'm also available to you by email if you have additional questions. But I skip a couple of the slides in order to have an opportunity to discuss with you and to focus on the main issues, on the political issues. Whereas the public system and the private system have different problems. The public system sustained major reforms in 2004, and since then, basically, the cost containment works reasonably well. Currently, in Germany, the percentage of GDP that we spend on healthcare is about 11.6%. This is not exceptionally high in comparison to other countries. For example, France, 11.8%, Sweden, 10%, Spain, 9.5%. So it's not, let's say, an exceptionally high GDP expenditure, and it's also stable. It has not increased in recent years. We made major reforms in 2004, 2005. I come to these reforms later, but ever since, the public system is not out of control cost-wise. Cost-wise, it is a system which is in control. It is paid for by basically three sources. There is a contribution rate. The contribution rate is income related. 15.5% of the wage goes to the health insurance system. 60% of this, roughly speaking, comes from the insurer, and 40% from the employee, from the employer. 40% from the employer, and 60% from the insurer. So these are the two sources that are let's say, wage-related contribution rate. Additionally, about 10% of the system are paid for by taxes, general taxes. So these are the three sources of the system. The cost containment, which we, let's say, put into reform in 2004, 2005, worked in hospital for primary and secondary care in physician offices, and also for drugs. What we did for drugs is basically that all new drugs have to be tested for their effectiveness and also for their cost effectiveness in order to be fully covered. And the price is regulated down if there is some effectiveness, additional effectiveness, but it is not a big leap in comparison to standard treatment. So a new drug, when it comes to the market, basically is tested twice. First of all, the company has to provide data, all available trial data, to the Institute of Quality and Efficiency of Care, which we initiated in 2004, which show that the drug is effective. And then additionally, tier number 2, the company has to provide data which allows the institutions which regulate prices to compare the new treatment with standard old treatment. And then there is a price negotiation for the new drug which takes into consideration how big the additional benefit is. This is different from what happens in NICE, which typically is only a question whether a drug should be covered or not, but where NICE in itself does not determine what the price should be given the cost effectiveness in comparison to standard treatment. But it is a similar mechanism. It's a comparable mechanism, and NICE and our EQUIC work together. They share portfolios and they also share information about how they evaluate particular drugs. In the hospitals, we had a per diem payment, therefore we had the longest length of stay in Europe, and we switched towards a DRG system, diagnosis-related group system, which lowered length of stay by 40% in a couple of years. So this is, let's say, how cost containment work in the hospital. And when it comes to physicians, what we basically did, we introduced disease management programs which lowered the number of major complications for diabetics, heart disease patients, asthma, COPD patients, and breast cancer patients. About 7 million chronically diseased patients are enrolled. I lectured about this an hour ago in a different lecture hall. I will not, let's say, repeat that lecture, but it is also available through Lawrence. So this is how we had some success, at least, in cost containment and improving quality of care in primary care. So in Germany, we really had major reforms in 2004, 2005. Those were reforms that we did as Social Democrats, and they were not very much liked by the physicians at that time, and also not by the drug companies. At that point, I myself was also, let's say, I was actually seeing quite a fair amount of criticism from doctors because the reforms were resisted by the drug companies and also by the physicians. By now, the situation is much more peaceful, and the reforms have worked well in terms of cost containment and also gave some contribution to the improvement in quality of care. These reforms did not extend into the private system. So the private system is currently more or less out of control in terms of cost control. On average, premiums in the private system rise by about 10 to 15% per year. This is a substantial rise, and it is a very substantial difference that this rise has made by now for retired people. The average monthly payment in the public system of a retired person is about 300 euros. This is a full, let's say, payment. There is no surcharge for age or comorbidities or existing conditions, and it is dependent on the retirement benefits. On average, 300 euros per month. In the private system, by now, the average premium is 800 to 900 euros per month, and there is an increase of about 10% per year. So many retired people, in particular those that have overestimated their retirement benefits from the private retirement market, with, let's say, the low interests that currently a lot of, let's say, the retirement funds are able to provide, to support. These people who overestimated their future income, they have underestimated their future costs in the private system. And the private system, in comparison...
This is about 30 to 40% or even more of their income.
Yes, very much so. I mean, there's even cases where you have 50% of the income. And indeed, the conservative liberal government, Mr. Barr, who spoke, whom you had the honor to introduce in this very room, he introduced a law now that allows the private insurance companies, for those people who are not able, the older people who are not able to pay the premium anymore, to have a kind of an emergency tariff, an emergency package. So the people who cannot pay, they pay only about 110 euros per month, but this then only covers emergency care, like accidents, major bleedings from a complication and so forth. But it does not cover full treatment. This is almost American style, as a matter of fact. This means, for example, if you have a complication from leukemia, a bleeding from leukemia, very often, let's say, in all later stages of leukemia, bleeding is a feared complication. Then the bleeding is covered by this emergency coverage, but the treatment of the leukemia is not covered. So this is a risky way. This is a new law, and it is Americanizing the private system, as a matter of fact. But the conservatives who resist the universal system have to offer something. And many people in the private system who cannot pay the premiums anymore, they have no coverage whatsoever. Because if you cannot pay, you cannot see the doctor. And this is becoming a bigger problem. So the privately insured, they have some additional advantages when they are younger. They are well liked by specialists. They get a quick appointment, but in their later life, they may sustain disadvantages. They may not be able to, let's say, enjoy the retirement benefits that they expected to enjoy, and they may no longer be that welcome because they are not able to pay anymore. And in that sense, the system, the private system is now under pressure from those that are publicly insured because they do not want to, let's say, have limited access to specialists because they are not privately insured. And the system is also under pressure from those who are privately insured because the privately insured who are 55 and older very often worry that in the long run they will not be able to pay for the premium increases, and therefore they want to they want to get back into the public system, which they are not permitted to do. It is only certain hospitals and certain physicians who want the system to linger on the way it is currently working. Very often, for example, physicians who live in wealthy environments because they have a high percentage of privately insured. If you work in a region which is, let's say, low income, high crime, and a lot of immigrants, for example, you see very few privately insured patients, obviously. So therefore, you may not, let's say, object to the reforms which we are discussing on this occasion. But if you are working at the Starnberger See, which is a very nice region around Munich, very nice, well-off region, where you have 40% possibly of privately insured, then you may mind our reforms. Therefore, among physicians, there is controversy, and among insurance companies there is controversy. The reform which I propose as a speaker for Health of Social Democrats, the universal coverage, roughly speaking, from the polls, is liked by about 80% of the population. This is not bad for a reform. Many of the reforms which I, let's say, described earlier, the reforms which we did in 2004 and 2005, and also the disease management programs which we introduced in 2002, we basically made these reforms against the opposition of almost all physicians, or many physicians, and a large percentage of the population. I think these were good reforms because they were cost-containing, they improved quality. So we basically did it because we believed it was correct. We did something similar for the labor market. We had, roughly speaking, the highest unemployment rate in Europe, one of the highest unemployment rates. We came up with, as Social Democrats, with major labor market reforms. We now have a very low unemployment rate, in particular for young people. We have the lowest young unemployment rate for young people. This was also a reform which was not well liked, and we were pushed out of government for the reforms we did. But the reform which we now propose, the universal coverage reform, for Social Democrats is actually almost an unusual reform, because it is a reform which is liked by the population and is beneficial to the population. So in that sense, it is, it is almost, we do not exactly know how to market this reform, because we have become so used to market a reform where we expect the resistance. So this,
can I raise a point here?
Surely.
If you implement the reform, you're going to have against the doctors, the pharmacists, and the dentists who are likely to make more than 4,000 euros a month, all of them, and all the civil servants because they're under the special arrangements.
Comes to the civil servant in a second,
Yeah. So how are you going to implement the reform with the civil service and the health personnel against it, despite the fact that 8% of the population are in favor?
As the civil servants are a special group, half of the privately insured are civil servants. And the civil servants live in the best of the combinations of these systems, because 70% of their, let's say, bills is paid for by the government. Only 30% is paid for by the private insurance companies. So therefore, they have to insure only 30%. And even an increase of 10–15% per year is sustainable if it only, let's say, covers 30% of the total. So from the perspective of the civil servants, this is a good, the private system is a good system, because they get the full advantages of being a privileged patient. They still have the risk of being overtreated, but they are not really at risk for the cost increases. This is very difficult. And many politicians are privately insured, and civil servants. For example, Mr. Barr, who spoke here, he is privately insured. Ulla Schmidt, the Minister of Health, I was the primary advisor for. She is privately insured. Horst Seehofer, who was Minister of Health before her, from the Christian Democrats, he was privately insured, or is privately insured. It's the same for me. I'm also privately insured. I'm a civil servant, a university professor. So the system as it currently works very well for people just like me. And this is also one of the reasons why a couple of my colleagues, as a matter of fact, asked the question why I am lobbying for a reform from which they hope to benefit in the future. But as a matter of fact, we must basically, in order to be credible, make this reform for everyone. So if we change it for those who are privately insured, but not civil servants, we also have to change it for the civil servants. And this will be an uphill battle, but we will ultimately win it, because the big picture is, why should a system for the whole population not also be the system which works for those that design that system? We are basically the engineers of the system. Us, the university professors, the, let's say, scientists, the doctors, the politicians, we design the system for the population. So it is very difficult to argue that we design a system which we ourselves do not want to be part of. This is like you want to sell a car. You are a car engineer, but you insist on not driving the car that you have basically designed for someone, for other people, as a matter of fact. This is not, I mean, so therefore, the civil servants some civil servants will resent this, but they cannot be too public about it. We will survive this attack. We basically will ask for arguments. If, for example, a civil servant or the union of civil servants argues that they should be excluded, we will ask them as social democrats to be specific as to why that should be so. Give reasons. What are the scientific or economic reasons that can be made public why that should be so? In that sense, I don't expect to hear much from them. When it comes to doctors, this is different. For example, president of the German Medical Association, Frank Ulrich Montgomery, who is also a member of my party, as a matter of fact, he is a social democrat. And he actually announces this all the time, fortunately. But he very much resists our reforms. And he's basically saying that the quality of care will drop immediately if this, let's say, well-designed, intelligent, and historically driven system is put into jeopardy. He objects that this is an income issue, but he basically and he fears that we will have more of a two-tiered, two-class system if we come up with a universal coverage system. Whenever I ask him to explain this extraordinary logic, I find it confusing, as a matter of fact. So I suspect that income issues play a role, but this will be a big battle, as a matter of fact. But ultimately we will win this because we are supported by those who are privately insured and also those who are publicly insured. And the time is working for us, as a matter of fact. Because with these cost increases in the private system, the pressure on the private system is mounting very quickly. And all the doctors who do not have private patients, they also do not like to see the president of the German Medical Association to speak in their name, because they do not gain from these income differences. So in that sense, I think it will be a battle, but we are battle tested, and we will be able to survive this. Coming back to the issues, this is how the self-administration works. I've already explained this, how it is determined what is covered by the system or not. The private insurance system has also a major disadvantage in the following way, that it basically has to pay for whatever the doctors do. The private insurance companies cannot insist on a drug to be tested on the grounds of evidence-based medicine or any procedure. They have to pay whatever procedure is done. That makes the private system so vulnerable towards cost increases. Because whenever a drug or a procedure has not been shown to work well enough to be covered by the public system, the only market which is then left for the company is the private system. And since the drug company and the physicians are sitting in the same boat, they may, let's say, push a drug which is not working well and puts physicians at a legal risk if something bad happens, but definitely puts patients at a medical risk. Everyone here in the room knows that there was problems, for example, with the anti-rheumatoid arthritis drug Vioxx. Vioxx, a drug which, let's say, worked against rheumatoid arthritis symptoms, was many times as expensive than standard treatment, a very modern drug, but it was not much better. It was not better than, let's say, standard treatment, and it had major side effects. Some of these side effects indeed were deadly. For example, heart attacks and even strokes caused by the very expensive and new drug. The company was able to sell the drug even at a point when the results of the studies were already very worrisome. I mean, there is no major litigation going on in Europe and in the US because the company was, let's say, trying to sell the drug as long as possible, despite the fact that let's say, trial data available to the company and also to some research groups are already very worrisome. And this was a bigger problem in Germany to the privately insured than to the publicly insured, because it was not covered other than for a couple of exceptional cases for the publicly insured, but the private companies had to pay for all patients. So therefore many of these major complications actually happened in the privately insured. The drug was marketed in the private sector because in the private sector, the companies, the private insurance companies, they have no safety mechanism in order to make sure that they pay only for what is shown to work. So they very often pay for treatment which is risky, as a matter of fact. I've already pointed out that the privately insured also have advantages. They have quicker access to specialists, but it is what you would perhaps call a mixed blessing. What you get may be expensive and good, but what you get may also be expensive and risky. So it's a mixed blessing. And many privately insured patients want to see more safety in the system. So we get this support. And in the long run, with the cost mechanism, that the privately insured people can get whatever they want and that the companies have to pay whatever happens, the cost increases are very steep. There is also some groups which support us heavily, and I will point out one group in particular, which is not the civil servants, but the group of the ex-wives of civil servants. The ex-wives of civil servants, they are privately insured 30% by their husband, 70% is paid for by the government, but only as long as you are married. If you are not married anymore to the civil servant, then you must insure yourself privately. And if you are 55 and older, you have to go into the private system. You cannot return into the public system. Now, let's say divorce among civil servants often happens if the wife is not young but old. Therefore, let's say, I'm not sure what the demographics here is, but so this and for these wives, ex-wives, I should say, for these ex-wives, then what they get in terms of, let's say, support by their ex-husband is often exactly what they need for the private insurance company. So they do not pay 30% or 40%, what many retired people pay, but they are asked to pay 100%, basically, because the premium depends on age and risk factors. And if you are older and already have existing diseases, you may quickly see a premium of 1,000 or 1,200 euros per month. and very often you do not get much more in terms of, let's say, support by the ex-husband. So now in the highest courts, there is cases pending where, let's say, it has to be decided who picks up this additional bill. Does the ex-husband have to pay more support for the ex-wife in order to make up for this, let's say, hardship? You would call it a hardship, I assume. Or is it in the responsibility of the wife, because she, in having, let's say, filed for divorce, she should have known this risk pending? So is it a hardship that she should have sustained, and if she opted and so forth? Or should, what the companies actually recommend, the private insurance companies recommend, should this be paid for by the taxpayer? The private insurance companies and indeed some of the physician groups say that the taxpayers, most of them being publicly insured, should pay for the ex-wives of the civil servants who already had a questionable benefit in the past. So even from the ethical perspective, this is a murky issue, and it is currently pending in the highest courts. Needless to say, the group of the ex-wives of civil servants is a support group for us as Social Democrats, because they would like to come back. But there is also more, I think, meaningful. Let's say, there's also other groups that support us, which I think are very important support groups. The private insurance companies never take adult disabled people. They don't have to take, so they basically reject disabled people, period. Even with diabetes, it is almost impossible to privately insure yourself. The surcharge is basically beyond your imagination. And if it is a genetic disease or a major disease, you will not get private insurance, whatever surcharge you are prepared to pay. In that sense, the private system completely discriminates against disabled people. But if you have a disability, having good and quick access to specialists, in particular in university institutions, may be important to you and may, as a matter of fact, even make a difference to your future health care. So in that sense, this is a very important discrimination, which we as Social Democrats take very seriously and point out to everyone who is, let's say, interested in the issue, apart from the question, what is this doing to the income of particular physician groups? And we have a number of support groups in that sense. So I think that this will be a major reform battle in Germany, but the outcome, I assume, in the long run is that we will win this. In the long run, the support is coming from the patient and from those groups that are currently sustaining major hardships and that do not benefit from the current system. Well, this is more specific, so I will skip this, and this is all about how we evaluate new drugs, how we evaluate new procedures, who decides what is covered and what not. The slides are self-explanatory to a large degree, and if there is additional questions, obviously I'm available for this. But I want to conclude basically with a couple of general remarks. In Germany, we clearly have more work to do than to come up with a universal coverage system. The universal coverage system is a very important step to make our system more equitable, more sustainable, and to, let's say, bring in more safety for everyone. It's a very important reform, but additionally we have more work to do. We have to come up with a good incentive scheme, a working incentive scheme for preventative medicine. In Germany, prevention at the moment is underfunded,
it is undereducated among physicians. We do not teach a lot of the prevention issues in medical school, and it is also underused in the field. In that sense, we must focus on bringing prevention into the field. And prevention is the field in which I'm doing most of my research. I have basically, my institute at the University of Cologne is an institute for clinical epidemiology, primary and secondary prevention, and health economics, a mixed institute, as you would say. And in prevention, currently research is bringing out new results, exciting new results, all the time. We have an explosion of knowledge, fascinating knowledge in prevention medicine. In particular, as we now better understand how the environment interacts with the genetic risks that someone does have. In particular, the field of epigenetics is becoming ever more important and also ever more influential. Epigenetics basically means if you have genetic good or bad luck, you inherit good or not so good genes. We now not only better understand what these genes are and how they interact, but we also understand how they are switched on and off before birth, in vulnerable times in childhood, and even later in life. If you have, let's say, a good genetic makeup, you may still be in a horrible shape later because you can switch off good genes and you can switch on bad genes. So the switching on those genes that help you and the switching off of those genes that are harmful individually is very important. And this can be influenced environmentally. So this is, let's say, how prevention currently moves. A lot of the research which we currently see is extremely fascinating in that way. For example, a lot of the nutritional epidemiology that currently comes from science looks in how nutrition interacts with particular genes. We, for example, learn how particular, let's say, so-called polyphenols interact with genes that then make your cholesterol less aggressive. Everyone knows that having, let's say, high cholesterol, in particular having high bad cholesterol, LDL cholesterol, is not so nice, and having high good cholesterol, HDL, is nice. But we have recently also understood that sometimes the good cholesterol is not working well and even may be harmful. The good cholesterol is not always good, but it is sometimes, let's say, neutral and sometimes even harmful. And this is due to the fact that the good cholesterol, the HDL cholesterol, can work anti-inflammatory, it can work neutral, it can work pro-inflammatory. So HDL does have inflammatory, let's say, effects, one way or another, apart from, let's say, what is known the cholesterol metabolism. And it's the same, by the way, with LDL. You can have, let's say, low LDL, but your LDL is, let's say, very aggressive. The LDL particles may be not dense enough. If the LDL particles are denser, then this is good news. They are not so aggressive. So in that sense, even the number of the LDL is not that meaningful if the LDL is not, say, more or less harmful and so forth. And how this works and how this interacts with risk factors. This is what is currently shown by major studies. This is fascinating research because it basically links genetics with environment, with epigenetics, and with policy issues. I'll give one example, a very simple example. We know that people who live closer to large streets have arteries in which you find more calcification.
So higher calcification, which is never good news for your arteries if you live closer to the street, to a, let's say, heavy traffic street. We also know exactly where the risk goes down. 50 meters away from the street is already considerably better. Third floor is better than ground level. 200 meters, no additional risk. And we also understand now where that is so. The fine particles which are in the air, they harm the vessels. And they do this by the very mechanism which I have just described. The fine particles interact with the genetic makeup in the artery vessel and work in a way that, let's say, bad genes that you may have are switched on and good genes are switched on. So therefore, if you have a very good genetic makeup, you have only good genes and not so many bad genes, the fine particles will not harm you. You can live close to the street on the ground. But if you have bad luck, so to speak, then you are better off to live on the third floor a couple of 100 meters away from the traffic and so forth. And a lot of this is becoming ever more clear. Fascinating knowledge, which let's say intellectually challenging. How the genes work, what you can do if you happen to have bad genes and so forth, how we can protect our children, how we can protect the unborn. So a lot of new science, extremely good science, very good science. But we do not put it into practice. So this is something that the German healthcare system has to focus on. I gave a lecture on secondary prevention in the disease management programs, I think 2 hours ago. And an older gentleman criticized me for not having focused enough on primary prevention. He was pointing out that all of this is working much better in the UK. I hope he is correct about that, but nevertheless, he is right that we do not focus enough on primary prevention, so this is also a major issue for us as social democrats. This also includes that we have to invest much more research money in these activities, and we have to come up with more professors who teach this and do research on this field in our university settings. We have only 5 big departments which do this type of clinical epidemiology in our 36 medical schools. This is not enough, by far not enough. I mean, you may think, what would you expect from someone who is a professor than to ask for more money for his field? But I think that it is actually justified. It is not the standard recruitment of more money, but here we have an explosion of knowledge and we do not bring it into the field. Number 2, what we also have to focus on is we have to make sure that the patient becomes more knowledgeable about his disease and the system, because empowering the patient makes a big difference. We know that those patients who know more about their disease have a better understanding of the disease, even if they have otherwise the same risk factors, have better outcomes in the long run. Studies show that those patients who are more knowledgeable about their disease have better outcomes. And this is a very important knowledge. I gave an example about this in the lecture I gave before. For example, if you are a diabetic, very often the first signs of a heart attack are not major, sharp shots of pain in the arm, what you very often have in non-diabetics if a major heart attack happens, in particular in younger patients, but you have stomach pain, major stomach pain. You have stomach pain which is not going away and is dull and very tough. And if you are a diabetic and know that major stomach pain which is dull and tough may be the sign of a heart attack, this is life-saving knowledge, as a matter of fact, because then you are much more likely to get to hospital in the time frame when we can still do a lot for you. And there is a lot of knowledge of that sort which people do not know. So patient empowerment is extremely important, and this is number 2 on the health agenda. And number 3, we have to continue to, let's say, make sure that whatever gets into the system is working. Because nothing is worse than expensive treatments which are not working. People rely on this. People, let's say, expect the things to work, in particular if something is expensive, because it is very plausible that something that is expensive is also working. But if that is plausible but false, this is very risky. In that sense, we have to make sure that all new treatments are tested whether they work or not. Not exclusively by randomized controlled trials, because very often such trials are not available, but by whatever best evidence is available. So we have to make the system more accountable. These are the 3 major, let's say, structural reforms that we as Social Democrats have proposed. We have also many minor reforms which I do not want to explain by now, but we want to modernize the system, and we want to, let's say, openly deal with the problems in the systems that we do have. We reject the rhetoric that we have the best healthcare system in the world. First of all, we don't think that it is possible to say who does have the best healthcare system in the world. All major systems have some advantages, have some disadvantages, and you cannot compare this. This may be, let's say, the can-arrow situation, the can-arrow problem of, let's say, comparing healthcare systems. But I know I've consulted and worked in many healthcare systems, and I know that there's a lot of good and a lot of bad in all systems. So we do not want to be in the business of, let's say, comparing all systems to other systems and basically explaining that we have our problems, we want to solve those, and we want to work together with others who want to solve their problems in fields we have experience and where we think we have done something. This is at least my impression. I would like to thank you for your very generous attention, and I'm very much looking forward to your questions, which can cover what I have talked, but also any general political issues that you may be interested in. So thank you. That's it.